Okay, I think we're all set. What time is it? Yeah, time to get going. Okay, good morning. Hope you're all warm enough. It was so loud. We're almost done with this chapter on neurotransmitters, okay? I think I've got a couple slides after this, and then we're gonna start chapter 4, part 2, where we're not gonna have pathways. It's all vocab, mostly vocab, all right? So you give a break, all right? So I left off, I believe, yeah, I just wrote these things in. But what I didn't get to is under glutamate, I didn't add additional information. This is the only slide where I'm going to talk about. Now, do you remember when I talked about glutamate toxicity and Parkinson's and even Alzheimer's? This is relatively new information. When I say relatively new, in the past 10 years. So in your generation, you might see more pharmacological treatment for glutamate toxicity because it's relatively new research that's found it out. But of the 3 non-monoamine neurotransmitters, this is the only one that's stimulatory in the brain. So there's 2 neurotransmitters that I'm teaching you. There's many more. Acetylcholine is always stimulatory in the brain, as evidenced by loss of acetylcholine-producing neurons in Alzheimer's. That is one of the things responsible for the problems that you see with Alzheimer's is low acetylcholine, okay? Glutamate is also stimulatory in most of the central nervous system, so brain, spinal cord, all right, but brain heavy. Glutamate toxicity. Too much of a neurotransmitter is just as much of a problem as too little. And so we're finding out that this can be a problem. Okay, so that's all I'm going to mention about glutamate. Then I'm going to talk about glycine. I said serine in the spinal cord. So glycine is serine in the spinal cord. This neurotransmitter, it acts in the spinal cord. And believe it or not, you're using it every single day. So I'm going to get back to kind of how muscles work. So glycine is inhibitory, opens up chloride ion channels. So we know chloride is inhibitory. You find it in the spinal cord. It's an interneuron. Remember at the beginning of the chapter, I went over neuron anatomy and I talked about interneurons and I said, I'm not going to talk much about it. This is the one time I'm going to talk about it. So it says here, it coordinates muscle movement by regulating antagonistic muscles. Now, I don't know if you learned in anatomy, there is a muscle that's being stimulated to contract. All right, muscles are arranged on our body such that this muscle on the anterior body surface tends to move a limb into the anterior plane. Muscles located in the posterior surface move a limb to the posterior plane. All right, the biceps brachialis, bend your elbow. Triceps brachialis, extend it. Those are antagonistic muscles that do the opposite action at that point. So if you have to flex your biceps, remember this is all voluntary. Obviously, biceps brachii muscle stimulated by the musculocutaneous nerve and releases acetylcholine into the synapse, finds the nicotine cholinergic receptor, causes the muscle to contract. Now, what happens is in the spinal cord, while this primary muscle is being stimulated to contract, an interneuron is releasing glycine into the spinal cord so that the opposing or antagonistic muscle, the triceps brachii, relaxes. Because if both these muscles contract at the same time, nothing happens at the joint. So in order to get the primary muscle to contract, you must inhibit the antagonistic muscles with glycine in the spinal cord. So you want to bend your knees, hamstring muscles, right? Glycine in the spinal cord is going to be inhibiting the quadriceps so it doesn't fight the action. That's how all our muscles act all the time. So glycine is pretty darn important in that part. That's how it's acting. So we can move around because we can inhibit the muscles we don't want to block the effect. Now, when you breathe, you have a lot of respiratory muscles, okay? But the main one is the diaphragm. Now, when it contracts, it kind of bows down, expanding your thoracic cage. And then when it relaxes, it compresses the thoracic cage. It's smaller, and then you expel the air from your lungs. And that's a passive process by the diaphragm relaxing. What makes the diaphragm relax? Glycine. Okay, inhibit skeletal muscles, allows them to relax. Okay, now, so let me add something here. It's like a little red marker because I'm going to add something here. Make sure my pen is working. For a primary muscle to contract. An interneuron in the spinal cord inhibits its opposing muscle. I'll say antagonistic. I think it's good to keep using that vocabulary. Antagonist muscle with glycine. It's a pretty important neurotransmitter. It does more than just that, but that's enough for us in the interest in neurotransmitters. Now, strychnine poisoning, I doubt you'll see that. Maybe in the olden days when people want to do someone in for their insurance or whatever, you can poison someone with strychnine. I saw it in the veterinary world because people can be jerks, and animals that they want to get rid of, they'll throw over some meat into someone's yard and it's poisoned with strychnine, and the animal dies an agonizing death. They basically can't breathe. So strychnine inhibits glycine. Glycine is supposed to allow your muscles to relax, like your diaphragm. So if you inhibit that with the strychnine, the diaphragm can contract. You can take air into your lungs, but you can't expel it. So functionally, you're not respiring. You're not ventilating. Because if you can't exhale the air out of your lungs, you can't then take in the next breath of fresh air. And so you asphyxiate and you die. All right? That's pretty horrific. So I hope you don't see it. Now, one of the last autoimmune acid neurotransmitters is GABA. We've talked about GABA before, okay? So GABA is inhibitory, like glycine, but GABA is in the brain, not the spinal cord. So I'll underline that. Glycine is serine in the spinal cord. GABA got to be, I think, brain. So GABA does a lot of things. We'll talk about it in the next chapter, which we're starting today. It helps coordinate muscles, all right? Especially important in the cerebellum, which we'll talk about in the next chapter. So GABA, let me put two things down. It calms the brain, and I have it written down below, and inhibits skeletal muscles. During sleep. And it does many other things, but this is enough to introduce it, okay? Now, Xanax, very popular anti-anxiety medicine, all right? People pop that stuff like hair candy. What it does is it calms you down. I tried one time. A friend of mine had one. You ever tried Xanax? I'm like, no. I trusted this friend, so I tried it, I hated it. It really makes you feel like you've had a few drinks, all right? Kind of mellows you out. So Xanax calms panic attacks as a GABA agonist in the brain. GABA calms the brain for someone having a panic attack. They're in fight flight in the brain, right? Xanax will calm them down. It doesn't work on everyone, all right? So that's a GABA agonist, one example of a GABA agonist. So here I put it here. GABA, when you're in deep sleep, when you're unconscious, you're not supposed to get up and walk around. I think I mentioned one time, did I mention when I was a kid? Yeah, I got up, I was probably 7 or something like that. I got up, I was sound asleep, but I got up and I started walking to the kitchen door to leave the house before my parents stopped me. Because my brain wasn't fully mature yet. So when you're in deep sleep, GABA is supposed to inhibit your skeletal muscles so you don't get up and walk around. All right. Interesting other story that I knew recently, a friend of mine, his wife, has started to really suffer from dementia, as can happen, you know, she's 70 something. And that does affect your brain function. And something interesting happened with her that seemed to interfere with her GABA inhibition of skeletal muscles in sleep. She was supposed to be in sleep. Husband was just sitting just right on the other side of the wall watching a football game on TV, and she was asleep. She heard a loud crash. She doesn't remember a thing. Apparently, she got up during her sleep. She fell. I don't know how she fell. She broke her femur. So GABA was not. She got up, still asleep. You're not supposed to. Okay. If someone develops sleepwalking as an adult, that's abnormal immediately. Okay, like this one. In a young child, it might not be because their brain's still developing. right? So that was definitely abnormal, but then again, her brain is abnormal because she's going through dementia. So insufficient, low GABA is associated with Huntington's disease. Does anyone know what Huntington's disease or disorder is? You'll see it. It's not all that common enough. It's autosomal dominant genetic disorder. If you inherit one allele, either from your mother or your father, you're going to show the disorder. Downside is you don't tend to show the symptoms of it until you're probably in your 40s. So you might have already had a family and probably passed it on. But what happens is it's a slow progressive. Yeah, come on, loss of muscle control. My pen is acting funny. So they will have uncontrolled muscle movement. Okay, it's called dyskinesia. I'm not going to write that down. But they might, and it could look like Parkinson's, but it's not. But they can have really unusual movements. They get to the point where they can't even walk anymore because they can't control their balance enough to walk. And so we don't know a cure right now. All right. But if it's low GABA, you might want to treat with a GABA agonist, not necessarily Xanax, but there's some other drugs that work as a GABA agonist. I think I've overwritten something here, but notice I put Valium here. How does Valium work again? Remember, it's one of the 3 drugs in the treatment of cholinergic syndrome. There's 2 PAMs, there's atropine, there's Valium. What does Valium do to the body? Valium. A muscle relaxant? It's a muscle relaxant. People take it just to chill out, all right? And it's one of those lists of drugs that gets abused because it can be addictive. So Valium, why is benzodiazepine Valium a treatment for Huntington's disease or cholinergic syndrome? Well, it promotes GABA. It's a GABA agonist. Okay, so you wouldn't give Xanax to a person with Huntington's, but you would give Valium, all right, in a slow, that herky-jerky muscle movement, maybe enough that they can function and get around. Okay, but it also treats cholinergic syndrome, the muscle seizures that happen. It stops muscle seizures. And so you see how I'm trying to like in neurotransmitters, here's a scenario of disorder in someone, and here's a drug that either is an agonist or a blocker to that neurotransmitter. And these are common drugs. I'm not giving you the obscure ones. You'll learn those in pharmacology. Okay, last neurotransmitter, and then we're moving on, is nitric oxide. So late at night on TV, when the kiddies have gone to bed, that's when they have all the commercials for erectile dysfunction drugs, because they don't show it at 6 o'clock because the kids go to mom and dad, what do you do? And you have to try and explain it to them. But nitric oxide is actually a gaseous neurotransmitter in your body. It plays a role in dilating your arteries. Okay, so nitric oxide, so people who have cardiovascular disease often take basically nitrate, right? That helps promote vasodilation, especially in arteries surrounding the heart. So nitric oxide causes vasodilation. So here's what happens in sexual arousal. It causes nitric oxide production in the corpus cavernosa. You don't have to write that down. All you have to know is it activates, I'm going to cross off all this, a cGMP, second messenger. This cGMP dilates the arteries going through the corpus cavernosa. Remember the upper erectile spongy chambers of the penis. When those arteries dilate, the blood floods into those spongy chambers. Fluid trapped in confined spaces builds up tremendous pressure. It's like hydraulics, and you get an erection. Okay, so that's how that happens. However, after sexual stimulation is waned, or after everything's calmed down, you gotta get rid of the erection. You gotta get rid of the blood from the corpus cavernosa. So you've got to get rid of the cGMP in the synapse with smooth muscle of those arteries. And so the normal process is enzyme breakdown of the neurotransmitter, phosphodiesterase. So that breaks down the cGMP. The arteries clamp down. The blood is removed by veins. Okay. Without that blood in the spongy tissue, the erection goes down. Now with erectile dysfunction, and it's so common, you're going to see it as nurses, they come in complaining of erectile dysfunction, not being able to achieve or maintain an erection. First of all, get a good patient history. Do they have any depression, anxiety? If there's something psychological going on, that's the first thing. Don't jump right for the drug. Everyone wants to pop out those blue pills, but talk to your patient because it could be up here, not down there. All right. If they have poorly treated diabetes, untreated cardiovascular disease, and other illnesses, that could be playing a role in blood flow throughout the whole body, not just the penis. So there's other things. If you rule out, okay, I think this is truly just a blood flow problem, and there's not something bigger going on, you don't just want to prescribe the pills and they drop dead of a heart attack next week, right? Or you treated their ED, but you missed something else in their patient history. So erectile dysfunction drugs, they work by promoting blood flow to the penis, all right? So Viagra, Cialis, Levitra, and the other formulations work as phosphodiesterase inhibitors. They inhibit this enzyme from breaking down that. So more cGMP builds up in the synapse with arteries in the penis, and these drugs are cGMP agonists. All right, so the arteries stay dilated, you can get blood into the corpus cavernosa chambers, and you can achieve an erection. Now, if you listen to those commercials on TV or YouTube or the radio or whatever, they usually list the problem side effects, and they rattle them off really fast, but I've listened. Okay, if you experience any of the following, please contact your physician. Dizziness, loss of vision, okay? That's the main one. Here's another one, side effects. A possible side effect equals priapism. Does anyone know what priapism is? Priapism. It's an erection lasting longer than 3 to 5 hours. Okay, that's a side effect of taking erectile dysfunction drugs. Since they're one of the most commonly prescribed drugs, you should talk to your patient, say, okay, if you experience any of these things, you need to call us back, okay? You might need to come right in. If someone experiences an erection lasting longer than 3 to 5 hours, call into a hospital, into the doctor's office, okay? They say, I'm on this ED drug, Levitra, and it's been 4 hours and my erection won't go away. Come in now. Not tonight, not tomorrow, come in now. Okay, now. It's an emergency. Because fluid trapped in confined spaces builds up so much tremendous pressure that the tissue, soft tissue around that fluid can become compressed by pressure and experience pressure necrosis. That means death of tissue. Plus, it's got to be extremely painful to have an erection lasting that long. Okay, it can cause permanent damage to the penis, to the nerves, everything. So it is an emergency. Do you know what they have to do? You're shaking your head. Someone's shaking your head. So you have some knowledge. Nice and loud. They have to get the blood out of it. They have to take a needle to the penis and get the blood out of there to release the pressure. All right. And then they probably have some other drugs to maybe stop the whole cascade. I don't know, but I do know about they have to go drain the blood. Just like if someone had a hematoma on the brain, you got to go get that blood out. So yeah, not pleasant. There's always side effects. So any questions about that? All right, that's cool that someone knew that. Okay, so I'll post these notes today. Now, the next chapter, no flow diagrams. I don't believe there's any flow diagrams. Yay! It's all vocab. So this would be one you can get by with the index cards and Quizlets and everything. Okay, so central nervous system. Some brief anatomy review, but I'm going to really talk about the subdivisions of the brain and what they do. And of course, I'll get to some other neurotransmitters, some will review. But first of all, anatomy review. I assume that you know CNS stands for central nervous system. which is the brain and spinal cord. That's where the majority of all your body's neurons are located, centrally. Your peripheral nervous system is all nervous tissue outside the spinal cord. All right, like your radial nerve, your musculocutaneous, your femoral, all those are nerves of the peripheral nervous system. They meet at the spinal cord, but they're not part of the central nervous system. The more anatomy review, and I've got the pages in the wiki text where you can type in page 58 and you can go over it. But basically, from top to bottom, your cerebrum is the largest, most complex part of your brain. It is the most forgiving part of the brain if you have a brain injury there, because there's a left hemisphere and a right hemisphere, and it's duplication. So a lot of things that the left hemisphere has, the right hemisphere has an equal copy of. Not in all cases, though. All right, now your diencephelon is right here. It includes your pituitary gland, optic chiasm, your thalamus, your hypothalamus, the pineal gland is back here. Actually, the corpus cavernosus is part of the cerebrum, but basically that. The midbrain, small part right here, is called midbrain because it's smack dab in the middle from the upper and lower brain part. The pons is right here. I like to call it the pregnant belly of the brainstem because it sticks out to the anterior. And then the medulla right here, such a small part of your brain, but it does so many interesting things, vital things. And then lastly, back here is your cerebellum. So I think cerebellum, I think balance, things like that. Okay, now I gave one away, but what 3 of these brain regions makes up the brain stem? Medulla. Oops, no, go back. The pons, the medulla, and the one I just gave out, this one. Oh, that you already get, sorry. Medulla, midbrain. Sorry, that's it. So it's these. Now, this is called the brainstem. This is your body's autopilot system. This is your body's life support. You get damage to one of these parts of the brainstem, it's like damaging your life support, and that's not good, okay? You get damage to the brainstem, you're going to be put on external life support, unless that part of the damage can be repaired, all right? So we'll talk about the functions of these a little bit later, but things that control your respiratory rate, your heart rate, your blood pressure, things like that, all right? That keep you alive, life support. All right, divisions of the brain. Did you guys have some subdivisions of the cerebrum and their functions, or you just have to recognize that's the frontal lobe, that's the parietal lobe, that's the temporal lobe, that's the occipital lobe, and if you spread these two apart and look inside, it's the insular lobe, all right? Now, when you took anatomy, did they try to say the frontal lobe does this, the parietal lobe does that, the temporal? Good, so this is easy, all right? Just want to make sure you got it. So in the frontal lobe, that's your motor cortex. And your motor cortex is right here. That's your motor cortex. I'll put the MC. Oops, nope. Go away. MC. That's controlling all of your voluntary movements. Kind of a thin little sliver, isn't it? And so all your voluntary motor activity, skeletal muscle activity is controlled there. Now the Broca's area, I'll put a big B, all right? Broca's area is the motor speech area. It's for all the muscle movements, including your tongue, your voice box, your larynx, everything, to produce sound, to produce language, okay? For speaking. And then most anatomy textbooks don't include it, but I'll ask you. Right here, I'll put a little arrow to it. It's the prefrontal EFC. Did your anatomy textbooks cover the prefrontal cortex? Okay, the prefrontal cortex does a lot, but it's your higher thinking, your higher cognitive abilities, primal emotions, your identification, your self-ID, that you know you are a different person, and it develops in a child, right? And they recognize I'm different from that person right there. I'm a unique person. The reason, now you probably had this in your anatomy textbooks, the case of Phineas Gage. Some of you, yes. Olden times, okay, but he was a construction worker. And in construction, you pour concrete, you put rebar, which is a metal rod, to help strengthen that concrete so it doesn't fall apart. And so, and also in development and building, sometimes we use dynamite. So what happened is there was some unsafe dynamite storage, and there was an explosion, and it blew apart some concrete, and the rebar in the concrete went flying, and it went through his brain, and it went through the prefrontal cortex. And before the accident, his friends described Gage as placid, friendly, good guy, never swore, polite. After the accident, because that rebar destroyed his prefrontal cortex. After, they said he's no longer Gage. Okay? Think of a patient who has brain damage to that part of the brain. Their family members are it. I say, I don't even know this person anymore. Okay? When you get an extreme deviation from normal behavior in a patient that's had a brain injury, that's hallmark of brain injury is sudden change in disposition and personality. Okay? So he swore, he was violent, he had no impulse control, really kind of not a nice person to be around. And unfortunately, once it's gone, it's gone. All right. So that's the prefrontal cortex, but actually is kind of important. Now the parietal lobe right here, and let me move this stupid thing out of the way. Over here. Okay, parietal lobe, I'll put it in a different color. Make it black, so it stands out. Right here is your sensory cortex. It's also known as the post-central gyrus. The motor cortex here is known as the precentral gyrus. Here's why. The name of the sulcus here, dividing down right there, is called the central sulcus. So they name those cortexes before the sulcus or after it. So the sensory sulcus is responsible for your perception of all sensory things going on in your body. And I think we have a sensory lab this semester. Yeah, after the taste lab. All right. And right here, and I'll put a big W, bless you, is the Wernike's area. But most textbooks kind of get it wrong. It actually spreads into the occipital lobe. I'll explain. But the Wernike's area is important for understanding the written and spoken words and understanding language. And I'll get to that in a second. That's important. So when you're understanding language, the written word you see with the visual cortex. The temporal lobe, which I'll get to, has an auditory cortex for hearing. And then the parietal lobe has a whole bunch of sensory stuff. So that your language and comprehension involves multiple lobes of the cerebrum. And the Wernike's and Broca's area, let's make a note here. Area are left cerebrum only. They're found on the left side. There isn't an approximate or equivalent one on the right side. So if you damage those parts of your brain on the left side, you don't have a backup on the right side. All right, and that can cause problems. The temporal lobe right here has an auditory cortex for perceiving and understanding sound, and then an olfactory cortex because it receives your olfactory nerve that comes through down into your nose. It receives that. So that's olfactory or sense of smell. And it also has part of the Wernike's area. The occipital lobe has the visual cortex. So someone falls and hits their head and they present with blurred vision, they probably got a pretty good tap to that visual cortex, and hopefully that vision comes back. But sometimes you can get damaged so bad it doesn't. It also has part of the Wernike's area. And then the last part, which we can't see between the frontal and temporal lobes, is the insular lobe, which we're going to be testing this week in taste lab. So it has a gustatory cortex through your perception of taste. So it's receiving information from your taste receptors on your tongue. And I'm going to mess with your taste receptors next week with a harmless herbal tea. All right. Okay. Now, precentral gyrus is the motor cortex. And postcentral is the sensory cortex. Now, do not memorize this image. I even have it on the slide. Unless you end up being a nurse working for a neurosurgeon, there's some really good neurosurgeons in the cloud. And then you might want to know this. So you ever heard of a brain map or brain mapping? This is a brain map. So they know that along the precentral gyrus and motor cortex, down deep in the longitudinal fissure, which is basically where that central focus is, deep at the bottom of it, that is motor control of your feet. And then as you go up to the top, legs, pelvis, as you go over the top of the motor cortex, it's arm, trunk, arm, And as you come out to the side, it's fingers, face, salivation, swallowing, things like that, as you come to the outside. So if someone, yes. Is that what? I've heard that, but it's such an old term, I'll have to look at it. I think I once knew what that was, but I haven't thought about it in years and years and years, but I'd have to look. But it is a map of motor function in the motor cortex. So if someone has brain injury, you sent them to a CT scan or an MRI, or they have a tumor or a lesion, and you see it here, and it's in front of the central focus, you're like, this person, this explains why they have motor deficit in this area. They've got damage or a lesion, or they got, car accident or something. Now, I wish I brought my teeth. Sorry about all this. The sensory cortex, which is behind the focus and blue here, has a sensory map. So if someone has brain damage or lesion there, all right, down the longitudinal tissue, that sensory perception of the groin, the feet, as you get around the top, the legs, the pelvis, around the top, the arm, as you get on the outside, face, lips, teeth, tongue, pharynx. Sensory perception of those parts of the body. And so if you know where the damage is from a CT scan or an MRI scan, like someone comes in a car accident and they're unconscious and you send them to a CT scan because you want to know what the damage is. And if you see damage in the sensory cortex, they're going to have a sensory deficit. If you see damage in the motor cortex, depending on where it is, you're going to have a motor deficit. All right. The patient wakes up and they say, why can't I move my legs? All right. Why can't, or you touch them with a pin and they're like, you're like, do you feel that? And I'm like, no. That would explain it from a CT scan. Okay. So, got time here. The cerebrum and language. I'm going to spend a lot of time talking about the cerebrum. Since the language centers are only on the left hemisphere of the cerebrum, if there's damage there, you got a problem. So the Broca's area is the motor speech area. It's already written down, but I'll say here, motor speech area. For speaking. So it's motor control of speaking. People who stutter, they likely have an issue in the Broca's area. If someone has a stroke and that part of the brain right here, Broca's area, goes without blood supply, it could damage it permanently. Someone who has a stroke could recover, and all of a sudden, in addition to maybe partial facial paralysis, maybe because part of the motor cortex is damaged, if part of the Broca's area is damaged from lack of blood flow, that's probably not coming back. They're going to wake up and all of a sudden they're going to have a hard time speaking. All right, you would have seen it on the scan. Wernike's area, all right, so here is B, this is W, is your language comprehension. Or comprehension of the written and spoken word. We've learned a lot of that from people who had strokes or brain damage or whatever that these areas are involved in. And then you'll see in your patient, they'll have these deficits. And this is something that, if this is something that happens to someone, they need to go see a speech language pathologist because they will work with them to regain what capacities they have. Okay, so aphasias are communication disorders that result from damage or injury. It's possible someone could be born with it too. It could be congenital. So Broca's aphasia is called non-fluent aphasia. They can't get the words out, all right? They understand language. Fine, don't treat them like they're idiots, okay? But they have difficulty talking. So if you have a patient come in and it says on their chart, Broca's aphasia, you need to be very patient and understanding with them. Don't be impatient, don't be rude, don't treat them like they're idiots, okay? Can you imagine how frustrating it would be if you understand everything that someone's saying to what you're saying and everything, but you can't get the words out, you can't communicate with them, all right? It's going to be incredibly frustrating and embarrassing for a patient. So I've got my speaking, I'm going to test it out, a YouTube video of a patient that has Broca's aphasia. begin here. Make sure my volume's all the way up. Come on, speaker. Oh crap, it's not working? Really? What a letdown. Let me stop for a second. Maybe my speaker waited so long to communicate that it disconnected. Yep, that's exactly what happened. Okay, let's try. It was working when I started. Connect. Oh, burn. Figure out something else. Something about hooking up to HDMI cable that made this impossible. Well, that's too bad. No, don't check my speakers. No, I'm not going to waste any time. I wonder if I can get it loud enough on this. I don't know if my computer's audio is going to be loud enough. I'll turn this off. The patient, the doctors or speech language pathologist is asking him questions like, can you give me the days of the week? And he goes, no, no, no. And if the pathologist gives him a helping hand, Monday, then he goes Tuesday, Wednesday. I'm not mocking him, this is exactly what he sounded like. And he was supposed to, the doctor asked him, okay, what town do you live in? Okay, what state do you live in? And he struggled to get it out. He knows it, but he's having a hard time getting the words out. And so you have to be really, really patient. And the next one was very good too, and I do recommend you listen to it, is Wernike's aphasia, which is called fluent aphasia. You have difficulty comprehending language. Comprehending language. Now I'm going to try something out here. But you can speak fine. And what you speak, it's word salad. So what I'm going to do is I'm going to see if I can disconnect the HDMI. So this projector is going to go blank. And I'm just going to try and play it from my computer so you can listen to it. So let me escape out of this. Take this off. Because it really is something. No, it doesn't like it. There we go. Okay, so now let's test it out. It says it's connected to my speaker, so let's try it out. There we go. Please work. Oh, bummer. It won't. When I go back to my office, it'll work fine, but for some reason, putting this cable into the computer just messes everything up. Oh well. So you have to listen to it on your own if you're interested. Okay. So we're going to go past that because I can't do anything. But what I will say when this wakes up again is I don't want to discourage anyone from applying and going to the nursing program. It's a great program. But there's other things that you can do working with patients in a hospital system other than nursing. And one of those is speech language pathology, and we have a program here at FMU. If you click this link, it brings you to it, okay? And so that's a master's degree. So you'd have to finish with a biology degree for your biology degree, bachelor's degree of science. And then you have to take a couple prerequisite courses you can take at their speech language program, then apply for the program and get in, all right? So prerequisite, how about program admission? So bachelor's degree, this is your or related discipline, bachelor of science degree in biology, all right? Minimum of 3.0 GPA. You have to take because it's a master's program, you have to take a GRE, and then you've got to have some shadowing or volunteer hours because they want to know you've been exposed to that profession, and this is definitely a profession for you because they don't want to accept you to the program and then you get into the program saying, I hate this. So that's pretty reasonable. Prerequisite courses, you're going to have a lot of them already just to get into the nursing program. So where are they? Biological sciences, you took 105, okay? You might have to take the lab 1 credit hour. Physical science, chemistry, you have to take Chem 102 just to be in this class. Statistics, that's a requirement of the nursing program. And you already have to take social sciences, all right? So you've probably taken Psych 334, one of your social sciences, you've taken humanities, yada, 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 okay? Now there's some other courses that you have to take, but you can take them at the speech pathology program and then apply to the program. So, because I called on this and to see. Now I have something else here. Get this out of the way. What do you make as a person with a speech language pathologist? So I've got the healthcare occupations from U.S. Bureau of Labor Statistics. And this page is for another course that I teach, but I looked it up. It's alphabetical. We're looking for S. Speech language pathologist, master's degree, 80K. That's more than I make with a PhD, a master's degree, all right? And you're working with patients and changing lives. So I just thought I'd put that up there because who knows? All right, any questions about that? Sorry about the audio. That was a very big disappointment to me too. Okay, so what happens, let me back up. What happens with Wernike's aphasia? If you watch that video, they'll ask the guy, I was wishing we went to the beach. The sun was fine, and we golfed there, and the sky is full of waves, and none of the words they say make any sense to you. You don't know what in the world they're talking about, but they talk with all the emotion and genuflection, and you know, like the way they sounds like normal speech, but what they're saying sounds like word salad, but it comes out so easy. They're not making a connection with what the words that are coming out of their mouth and what they mean. That connection is broken. So you really should listen to this because it's eye-opening to listen to that. All right. Okay, so moving along, and this is probably where we'll end it for today, the cerebrum and sleep. So there are lots of sleep clinics. Sleep disruption, sleep disturbance is so common. A lot of times it's stress. It could be lots of things, all right? It could be neurotransmitters. That could be a problem. But in sleep, you have, why isn't it advancing? Boy, my computer's having all kinds of problems today. There we go. So most of your sleep is get into the unconscious state. My husband, his head hits the pillow. I can't believe that. I wish I could do that. It takes me a good hour, and that's on a good night, all right? Because you go through these stages of going into deep sleep, and it could take an hour. It takes me an hour because my brain's like, do all the things to do today, I'll be in the day, things I got to do tomorrow, right? Worrying about that test. I used to do that. Sometimes I still do, so I do have some continuing edge. But yeah, you get to deep sleep. So this is non-REM sleep. REM stands for rapid eye movement that you see in someone who's fully unconscious with sleep. So REM is stage 5 of sleep. It's 20% of your sleep. You don't spend the entire night in REM sleep. What you do is you spend a little bit of time, depends on the person, maybe 20, 30 minutes. Then you cycle up to the earlier stages. You're slightly more aware back into REM and then see the cycle. Okay. Now, in REM sleep, your emotional brain is active. Your limbic system is active. So that's not going to hurt you. Have you ever had a dream where you laughed, or you cried, or you right? Seems so real because your limbic system is completely active when you're in deep sleep. And that's kind of the best part of deep sleep is that. But you have in your brain GABA inhibition of, I'll change the pen, so it's not the red, it's irritating. A inhibition of mental awareness of, I'll put unimportant stimuli. Okay. If you've become accustomed, and this is things you learn over time, if you become accustomed to someone snoring and you can sleep through that, you realize that's not an important stimulus. That's not a life-threatening stimulus. Some people listen to ocean sounds or whatever. That's white noise. Others, like when I lived in the dormitory, I had a lot of GABA inhibition because there's people up and down the hall playing music, active. It's like 1 o'clock in the morning, like, shut up, I'm trying to sleep, right? My roommate's watching TV low, but it's still on. And so I learned over time to block that out as white noise. That's unimportant stimuli. And so I allow my brain to fall asleep. Okay. The other thing, oh, let me get back to that. Now, when you're falling asleep, have you ever had that twitch, right? What's happening is GABA is starting to become dominant in your brain, and it's trying to quiet your skeletal muscles down. So your skeletal muscles are inactive. They're inhibited. You don't get up and walk away. During that process, which is not always smooth, it's not always like flipping a switch, the GABA switch, you might, as you're falling towards deep sleep, experience a myoclonus or a myoclonic jerk. My husband calls it the jimmy leg, or kick, right? And sometimes you jerk so much, you jerk yourself away. You go, what was that? Myoclonus, all right? What is happening is, oh, I don't know why, I read it. You have GABA inhibition of skeletal muscle movement. So you don't get up and hurt yourself. Because when you're unconscious, you could take a fall down some stairs, you could get up, walk out your door, walk out into traffic. Who knows what you could do? You'd be like this person I know who has dementia, who somehow got up and fell when she was in sleep, broke her femur. Now, so when you're in deep sleep, mental awareness is kind of plush, skeletal muscle movement is plush. If you're in deep sleep and your senses pick up a stimulus that is important, and this could be something you've trained yourself over time, like your alarm clock. You train yourself, I must pay attention to that. That means I have to get up, okay? You hear a fire alarm go off in your house, get up. You hear a baby cry, you get up. For me, if you hear a cat starting to throw up, I wake up out of a sound sleep. Especially if they're lying on me and it's going on. So we'll talk about what rouses you from this suppressed state next time. All right.
Scanner sound. Guess I have to figure that out. Mhm.
Both Maddie and I sent you emails about asking you for recommendations because we wanted to have it on paper, but we wanted to come up and
Okay,
ask in person.
okay, yeah, that's fine. I did get emails, I can respond because that's 10 o'clock.
Yeah. We just wanted to come up in person.
Yeah, and what you can do, and I'll email this to you as well, is send me a brief summary of basically things you're involved in outside of this classroom, because I only know you this little window, and I'm just getting to know you. And I'm gonna wait for most of these letters of recommendation after our first exam. We'll have some lab quizzes, we'll have lecture quiz, and I'll give you an idea. If you provide me with a summary of any extracurriculars, like you've been involved in a club, or you've been involved in events on campus, or you shadow or have worked somewhere at a hospital, or you've done some community service or something, anything like that, that gives me an idea of, other things about you, that helps me. a lot. Yeah, it doesn't have to be like, just summary, brief summary. Mhm. Okay, yeah.
Do you know if they allow high school teachers to have one?
I don't know, no. That, let's look at this,
Okay. Because it is getting to that time, and I'm going to look at the. I got to stop the share and stop recording. Hold on.